of involvement. So here we've got them on the left-hand side, and I'm going to lay, it's a left oblique axis, so they lay on the left-hand side. Now then, you remember that the features, and this is where I'm going into pure speculation, but I think that from what everybody does, it fits a kind of a muscle-based correction. When we look at this and we're examining the sacral sulcus and the ILA left, not only do we have the ILA left a little posterior, but we also have it a little caudal. More posterior than caudal. Okay? But this probably implies, and in fact this is what you feel, that there's been some influence of the piriformis on the right hand side, which has now become more tonic and has pulled this across to make that descend a little bit. And indeed this is tight, as we have tightness in the quadratus lumborum on the opposite side. There are a number of muscle features going with this as well. So what can we do to try and correct this? And I must say that I have a little difficulty in telling you what I'm going to say now. If the piriformis on this side is tight and kind of partially responsible for pulling this across, perhaps we should relax it. And of course the antagonist of the piriformis on this side isn't the piriformis on the opposite side, it's the medial rotator group on this side. So we'll need to try and work those to give us a reciprocal inhibition of this piriformis. Now, at the same time, if we can make that piriformis work, perhaps we can get this to move back into a reasonably correct position. And if we place the lumbar spine more or less towards flexion, then perhaps the tendency of the sacrum to be slightly into flexion will flatten out a little bit because of the general tendency of the rest of the spine to have its curves reduced. So that's the principle. We're going to try and work the piriformis on the left side and relax the piriformis on the right side, activating simultaneously the medial rotators on the right with the lateral rotator piriformis on the left. That's what I'm going to try and do. We'll take the spine into a classical position in muscle energy, which is to take the bottom shoulder back and the top shoulder forward so we've got rotation. We'll bring the spine a little bit into flexion, down to, but not including, the L5-S1 junction. That'll be stayed in its neutral position, presumably so that any correction can kind of take place with these minor muscle forces. So that's going to be the plan. And it seems to work moderately well, I must say. So I'll just get Chris here for a second.
Right on right just now, but you began with a left on left.
In this particular case, this would be the left on left position, because they're laying on the left-hand side. Okay? And we'll get Chris to do exactly the same thing. In my notes, you've probably got a right on right, I think. Okay? But the principles are, of course, exactly the same. So, I will gently take his shoulder, put his arm underneath him and to the back. I'm going to ask Chris to just move forward a little bit until he gets down to but doesn't include this joint. I'll probably stay a couple of levels, or at least one level higher than the L5-S1, because now I've got to go into rotation, and that's going to take up the last little bit of rotation and movement down to L5. I'm leaving L5-S1 in its neutral position. Then I'm going to take this up until I get into L5-S1, then I'm going to back off, which is very easy to do. Now then, his legs are just over the edge of the bed here. And that's important, that the whole femur is supported. If you have him kind of further over, it really digs in and he'll never do anything. Now, I'm going to put my hand in this fashion. I shall be resisting lateral rotation of the left leg and medial rotation of the right leg simultaneously. So I'm going to put my hand round like that, the rest of my forearm on the back of the upper leg, like this. So I can now say to Chris, now, can you just push up, or just hold, or push up in the air with both legs? And I can sense whether he's doing it with both or whether it's just one. And then relax. Take it down into a slight stretch position, then ask him to do it again. Just lift up, and down you go again. And lift up again, and down you go again. Now, the osteopathic explanation of this one is a sort of biomechanical thing of what the sacrum does. But if we've got the sacrum and the lumbar spine not really under any tension but in its neutral mechanics, it seems to me that the description doesn't follow what they are saying. And so for purposes of this, I'll go only with the muscle energy explanation, or not the muscle energy, but the muscle-based explanation of the action of the piriformis. The other thing is that in most people you see a slight increase of tension in the quadratus lumborum and the paravertebral muscles on this side. Now I know that we're going into the shortened position here, but in doing this, just lift up, they are activating the quadratus and the paravertebrals on this side. So perhaps that in a way brings about, because then I'm going into the shorter position of this, but I'm not activating it in any way. So perhaps there's some reciprocal inhibition going on there, which further enhances this technique. So just lift again and let it go down. I'm just monitoring at L5, S1 to make sure that I'm not inadvertently tightening up the posterior ligamentous structures at that level. Just lift again and down again, and lift again and down again. Okay? Sometimes you see the patient being encouraged to reach to the ground here. I haven't done that particularly for this particular problem, although I would do it if we were dealing with one of the extended lesions of the lumbar spine, simply because I think I can get sufficient rotation and flexion here, but I don't want to involve that L5-S1. I want to leave this in a neutral position there. So I think this is good enough as a stabilization for the rest of the spine. So that would be the correction of a left on left. A right on right would be exactly the same technique, except laying on the right side, because they are laying on the axis of rotation of the problem. I feel that this is much more of a normal kind of movement, and it's got stuck at the end of a range of normal movement. So it's not so dysfunctional. Whereas if it was a totally abnormal movement, which I feel that the right on left or the left on right represents more, although I know that some of my colleagues feel that this is a normal thing that goes on, I've found it more difficult to accept that, but the left on right or the right on left is much, much more dysfunctional than this is. But these are kind of nice to find. I know as a rule that you tend to find that people say that you find left on lefts more than right on rights. I'm really reluctant to not accept that, because I think it's probably true. But how do you know that the next patient that comes in, you can go back, Chris, doesn't happen to be the opposite one? And I think sometimes you tend to find what you believe will be going on, you know, and if 85% or whatever are left on lefts, sure enough, you keep on finding these jolly things. And sometimes it may be that you misinterpret someone because you just sort of rapidly go through this and then, yeah, let's get you down. So I'm always a bit reluctant to sort of say that, you know, mostly you find these, because I think it's a self-fulfilling prophecy, and you might miss those that just happen to be the opposite. So I think you find what you find in this given patient. All right, let us do that. And then we'll have a quick coffee. To the right, we obviously need to rotate it to the left. But if it isn't, and there's no particular problem, could we rotate the whole of the spine to the right to sort of effect a right correction of the sacrum, just to take it right down into the sacrum and make it look a more direct technique? And that's probably a kind of a reasonable assumption that you could do it. All that we've done as far as sticking with the same technique was that it seemed to work okay, and we hadn't got any reason particularly for changing because it was effective, but perhaps on those patients that it hasn't been effective on, to actually produce a right rotation in the way that we've spoken about, moving movement right down into the sacrum, is a reasonable assumption to do and make it a more direct correction from above instead of like an indirect correction from below. Now somebody else made another very good point, and it just eludes me at the moment. Perhaps it was when we're going to have coffee. We'll have it now, but just a brief time. Okay, I'm sorry, I've forgotten what it was. Somebody made a really good point. I'm going to have to walk around. Move on. All right. Let's take the situation now of having a backward torsion. And we'll take the backward torsion that has the same features as the torsion that we've just considered, which is the left on left. So now we'll be talking about the left rotation on a right oblique axis. And everything was the same with the exception of the lumbar spine, which was flexed. And it was flexed in a painful looking way. And if I have this kind of spine and try to do that on it, it would resist it. And if I ask the patient to come up like this, it would aggravate all of the symptoms. And if I held on to this, all of the signs would get worse if they tried to do that. So what I'm going to try and do is this. We'll just have a look at Fowler's technique here rather than the earlier technique that the osteopaths did, because I never could understand how it worked anyway. This one I can understand, so this is what I will teach you. So here we've got a patient, and it's really better if we have a table that comes up and down so that we can get the patient to the table like this, bring it up so that it's just about at the anterior suprailiac spine, so I'll simulate that with this, and they're already in this kind of painful position. This is like the typical Mackenzie protocol patient to start with, so they kind of walk in like this, and we can just simply say to them, just lean on there, and all of them can get down if they're supporting themselves in this way. Now then, we want to try and produce a little bit of fairly gentle movement, and at the same time as we produce this movement, the sacrum will be moving a little, and we want to try and produce a gentle pressure on the sacrum so that when the features of the sacrum get worse, we just counteract it. I guess it's a little bit like in the Feldenkrais things of this pacing and leading business, where you just give a little pressure. And what we're going to do is take the inferior lateral angle, and as that gets worse, we'll give a little tiny pressure. And then we're going to try and find the L5 transverse process, which we've said the speculation is that in this position it's rotated to the right. So my contact points will be inferior lateral angle left, around the iliac crest medial and onto the back of the lamina or the transverse process. Sometimes the lamina is a little easier to feel than the transverse process. And what I will do is I'm going to ask the patient to come up in a kind of a duck walk. A little bit here, a little bit there, a little bit there, a little bit there, and gradually extending. And as he's coming up like this, and I feel this wants to rotate to the right, I will give a little downward pressure. Just a little counter pressure, not a thrust or anything like that. And as he comes up and the inferior lateral angle wants to come more posterior or more distal, I'm going to give a little pressure there so that I maintain this pressure. So the patient will be doing this. I'll be standing behind, urging them on, and I'm just sort of very gently coming up like this. Actually not urging them on, they should just do whatever they can, to a point where they feel they can handle it. I would have this up a bit so my legs would be straight. Then come down a bit, down there. Okay, let's try again. Come upwards a bit like this, gradually trying to see whether they can come a little straighter. So I'll take Jim here and we'll have a go on this. Yes, please, Jim. Don't hide a body like this, Jim. Don't, certainly not. Okay, now just put your hands, just come up a little bit here, just hold your hands like that. That's it, okay. So I'm going to come into there and just into there like that. And as Jim sort of works himself up, can you come up, Jim, just a little bit one side and just alternately, that's it. And as I feel one side come up and push back into my hand, I'll just give a little pressure on that point. So I'm trying to sort of bring this into a kind of more of a straightened position. This is one I do even if I think it's a sort of discogenic problem. Can you go down again, Jim? But keep your sort of self, not too far, just into that position there, and it's sort of rounded here. Very often I will say, now, can you just come up again, just a little bit of time. Don't do too much rotation if I find that it, so he's just doing a little alternation thing like this. So I've straightened him up laterally if it was a McKenzie protocol. Now I still haven't laid him down, because you know sometimes that takes you half an hour to get them back up or to get them down. And so we can do all this in standing. We can do all our examination in standing that we need to do, this like truncated examination for this patient, and then sort of come up, just keep coming, just a bit more. That's good. Yeah, keep coming. Like this. And so I can use this for both the discogenic kind to try and get them so that they're straightened up, or for this which is showing me the features of the left on right. So we need to come up here, a little bit of pressure, and as he comes back into your hands, just give this alternate pressure back and forth. And this seems to satisfy a number of protocols. It's not going to be stressful on those you've misdiagnosed because it, or should I say, misanalyzed, okay? Because it was discogenic, and if this is a bit skewed and it is discogenic, doing this will probably be helpful anyway. So this is a very, very useful little technique that I was grateful to Cliff Fowler for showing me this. I think it's a successful one. Okay, thanks. Let's try this. Thank you, Jim.
So, but don't they think that what's happened is that...
For a moment. And let's just have a look at this particular scenario. Where when we examine this patient, and these are often where there are quite remote signs such as headaches and so on. When we look at this patient, what we find is that they are deeper on, let's say, this side here on the left side. We'll just take left-sided symptoms here. When we look at this, it appears to be more caudal on the left, the ILA. And this appears to be more posterior, but not as caudal. So in the former case that we did, this was more posterior and a little caudal. This is caudal and a little posterior. And this is what's called a unilateral sacral flexion. And I'll just kind of talk a little bit about this for a moment. We're examining our patient, all right, and we're starting with the kind of composite examination which we can just list tomorrow. We won't do it today, just so that we've got this complete little plan that we can follow. And what is said in Muscle Energy is that in standing, in the forward bend test in standing, if we find that there is a quicker swing of the ilia on one side or it ends up higher, it's indicative of a problem on that side of the iliosacral joint. And if we sit the patient and try the forward bend test, because of the increased stabilization on the ilia, it's more the influence of the sacrum on the ilia that does this in terms of a sacral problem. That sometimes takes a little bit of kind of accepting. But as a indicator, if they find that the sitting forward bend test is more definite than the standing, they're thinking a little bit about sacral lesions. Then when we start palpating with the patient in prone, looking for all of these points here, if we have the things on the same side, this is indicative of a unilateral sacral flexion. If we have the findings over here, it's grossly indicative of a torsion, but not which kind of torsion. We've got to examine the lumbar spine in terms of its extension or flexion to be specific in terms of which torsion it is, a backward or a forward torsion. So we find the signs on the same side. Now then, if this has gone deeper, and this has come more caudal, and this has become a little more posterior, how on earth can that take place? Because what we're saying is, this has gone like that, and that's come down. The only way that that could take place is if I had this, and that had gone like that, and that had gone like this, to get all those features. Now, the interesting thing is that we were in a group in Calgary, one of these little serendipitous experiences, and this girl had this thing that appeared to be, you know, like way down. It disappeared in here, and this was down. Cliff called everybody around, and we all came around, and there it was, his fingers sort of right down on this side. It almost looked like psychic surgery, you know, his hand had disappeared into the patient, and this had sort of come right down on the left-hand side. And Cliff was sort of saying that the last 3 patients he'd seen of this thing, he'd had them x-rayed, and all of them had a S1, S2 disc. And this girl looked behind him and she said, I've got an S1, S2 disc, and it's quite big. Because to sort of visualize the sacrum kind of bending and distorting is even beyond our belief, isn't it? I mean, it's built for absolute stability. It's got a curve in, it's massive, back to front, top and down. And we can't imagine, although bones bend, this is one that's built for no bending. So it may be that what we're looking at in some of these unilateral sacral flexions is perhaps the ability of the sacrum to deform a bit because it has got a disc between this and this. From experience of the osteopaths, and I must say mine has not been so great on finding these, is that these very often are involved in motor vehicle accidents with a twist with a lap diagonal belt, and in some way that seems to produce some of these problems. You know, and if this is the kind of patient, headaches tend to be looked for all up here. I think Earl feels that there's some form of kind of neural tension involved with this sort of setup. Although, does it change if we go into a kind of a mild slump, or if we go into an extension position which you'd think would take off any neural tension, as the sleeve goes into a concertina thing with the normal curves? I don't know. Perhaps you should study Brieg's book from front to back tonight and come up with a definitive answer on that, Kent, for tomorrow morning. Okay? So here we have this sort of thing. Now then, we're going to use one of these things where there may be a little bit of a controversy, okay, to correct this. We're going to say that we can't obviously get hold of this, little short of putting hooks in and pulling it back, to try and pull this back in terms of muscle or anything like this. And so what we're going to use is the feature that we felt the other day when we were doing that little bit of sort of traction stuff or flexion, that when a patient goes into inspiration, very often the sacrum will tilt backwards a little bit like this, come into an extension position. And so what we're going to do is to ask them to breathe in. We're going to try and say that that'll bring up the flexed side, and I'm going to put some pressure on this side in a cephalic direction and also a little forward, a little ventral. But because this is more exaggerated into being caudal, I'm going to put a little bit more rostral pressure on that at the same time as they breathe in. And when they breathe out, and it tends to go back to its original position, I'm going to try and maintain this pressure. Now, is it going to help to put a bit of pressure here? Well, it won't make it any worse, so I'm going to put a little bit of pressure on the right side as well. So this is where I'll be pressing. A little bit right, but more or less on the left-hand side going in a cranial direction with breathing. And I'll ask the patient to breathe 2 or 3 or 4 times, like incrementally. Breathe in a bit, hold it. Breathe in a bit more, hold it. Breathe in a bit more, hold it. And I'll be trying to hold the correct position. Then breathe out, and I'll try and really, really maintain the corrected position under these circumstances. So this will be the correction. Yes?
What's this for, left over right?
No, this is for a unilateral sacral flexion on the left.
Okay.
On the left, yes. All right, let us go to the table. Okay, David? Thank you.
Okay. I missed that part.
I didn't say it. Yes, please. And just put your pants down a little bit. Very well. Okay, so I'm going to take the inferior lateral angle there. I'm coming a little bit below it, and then I'm going to give a pressure in a rostral direction, a cranial direction, and I'm going to put just a little tiny bit of pressure on this side. I'll put very little on because I'll have my splint on there. Okay, so David, can you just sort of breathe in like 3 sections? I'll tell you to stop and then hold it there and then breathe in again and so on. Okay, so just like split it into thirds. Just breathe in, and I hold the position. As he wants to sort of come up, I hold it there. Breathe in again. Breathe in again. And as he breathes out, breathe out. I try and maintain a little pressure on here. Now then, sometimes you can make a slight difference by putting this into a position of medial and lateral rotation. And it seems to make more prominent this for some reason. I suppose it's sort of rotating this out a little bit. And then you can kind of hold that if you wish, if you've got a very much better position by turning this. Then I can come into here again, just breathe in, and breathe in, and breathe in, and breathe in, and breathe out. And I try and hold particularly this one. I'm not pushing too hard with that one. And breathe in again, and breathe in again, and breathe in again, and breathe out. Okay? Now I'll have a look at my correction again. So this is the correction of a unilateral sacral flexion. Let's try that, and then we'll have a break from doing this for a few minutes. Okay?
What was your upper hand?
It was just pressing on. Slacking off at the moment. What have we got to do? We've got to look at the concepts, and I'm not forgetting this. I just want to sort of change the tack for a minute, and hopefully it won't be confusing to you. I mean, I could do anything with you, group, and you're just so good, you would just not, nothing would